Welcome to today's deep dive. To start off, I really want you to imagine a factory, like a massive, highly efficient industrial complex that is operating right now, at this very second.
Right, just constantly churning.
Exactly. And its sole purpose is to manufacture and ship out high-grade explosives. So every single day, thousands of these, chemical payloads are packed up, loaded onto transport lines, and sent out.
Yeah, and the operation is incredibly precise.
Right. So precise that these explosives only detonate when they are miles away, deep inside a rock quarry, doing exactly what they were engineered to do. But, what happens if something misfires?
Oh, it's a
It
disaster.
really is. Like, what if a spark goes off on the factory floor and suddenly the very product that's meant to destroy mountains begins to vaporize the factory itself, tearing through the walls, melting the infrastructure, just setting off this massive chain reaction?
It's a truly terrifying scenario, and what's even more terrifying is that this factory is sitting right inside your own abdomen. You've just perfectly described the pancreas.
Yeah. Today, we are exploring this kind of biological betrayal. The pancreas is packed with these incredibly caustic chemicals, digestive enzymes, and they're designed to completely dissolve the food you eat.
Right, but when those safety protocols fail, you get a disease called pancreatitis.
And the organizing principle of this whole condition, like the core concept you really have to understand to grasp the severity here, is this process called autodigestion.
Yes, autodigestion. The pancreas literally begins digesting itself. It doesn't just get inflamed like a typical infection. It chemically consumes its own tissue.
Which is wild.
Yeah.
And to ground this abstract idea for you, we just need to look at the clinical evidence. Like the sources we're diving into today describe these really visceral bedside signs that doctors look for.
Yeah, they're quite striking.
There's Cullen sign, which is this dark bruised discoloration right around the belly button. And then Gray-Turner sign, which is a similar bruising but along the flanks, like the sides of the abdomen.
And those signs, well, while they're pretty gruesome, they're mechanistically fascinating. They were described over a century ago. And it's vital to understand that they are not bruises from some external physical trauma.
Right. It's not from getting punched or something.
Exactly. That deep purple and yellow discoloration on the skin, it's actually visual evidence of an enzyme called elastase.
Wow.
Yeah, it has escaped the pancreas, seeped into the abdominal cavity, and is literally eating through the walls of the patient's blood vessels.
Eating through the blood vessel.
Yes, it is the body's own chemical payload just dissolving its own infrastructure from the inside out.
It's absolute chaos. So if the stakes are that high, if a single misfire can melt blood vessels, we really need to understand how the healthy pancreas prevents self-destruction on a normal Tuesday. How does this organ safely handle explosives?
Well, it comes down to incredible biological packaging. The healthy pancreas is made up of these functional units called acinar cells.
Acinar cells, okay.
Think of them as the individual assembly lines on that factory floor. They manufacture our digestive enzymes. And we're talking about potent protein melters and fat dissolvers. Things like trypsinogen, proallistase, and prophospholipase A2.
Okay, notice the word you just used there. They all have ogen or pre at the edges of their names.
Right, exactly, because they are manufactured as inactive precursors. In biology, we call these zymogens.
Zymogens.
I kind of like to think of them as shipping unassembled furniture, or, to use your analogy, a bomb completely devoid of its fuse.
Ah, I like that.
So the pancreas physically packages these inactive zymogens into tiny storage bubbles called granules. And when you eat a meal, those granules are shipped down the pancreatic duct completely out of the gland and emptied into the duodenum.
Which is the very first part of your small intestine.
Exactly.
So they are totally harmless while they're inside the pancreas. They actually need a detonator.
Precisely. And that detonator is stationed far downstream. Waiting right on the intestinal wall is an enzyme called enterokinase. Its singular job in life is to encounter trypsinogen and cleave off a tiny protein chain, which turns it into active trypsin.
And then what happens?
Well, once trypsin is active, it acts like a biological spark plug. It rapidly activates all the other inactive enzymes, the elastase, the phospholipase, and they get to work digesting your steak dinner.
But that activation cascade is strictly designed to occur miles away from the delicate tissue that actually manufactured it.
Right. It's a huge distance, biologically speaking.
But, the body knows mistakes happen. If a detonator gets loose in the factory, the pancreas isn't just totally defenseless. The sources outline these three incredibly robust built-in fail-safes.
Yeah, it is the system built on profound redundancy. Failsafe number one is compartmentalization.
Meaning keeping things separate.
Exactly. Inside the acinar cell, the inactive zymogens are stored in completely separate physical compartments from the cellular lysosomes.
Right, and lysosomes are like the cell's garbage disposals.
Right, and they contain their own acidic enzymes, specifically an enzyme called cathepsin B, which can actually accidentally activate trypsin. So the cell simply keeps them locked in different rooms.
That makes sense. And then failsafe number 2 is a dedicated chemical inhibitor.
Yes, it's a protein called SPINK1, or PSTI. The pancreas actually co-secretes this right alongside the enzyme.
Like a chemical straitjacket.
Or a built-in fire extinguisher. If a few molecules of trypsin accidentally wake up inside the pancreas, SPINK1 immediately binds to them, locks up their active sites, and just neutralizes them.
Wow.
And it has enough capacity to handle about 20% of all potential trypsin activity. So it's an enormous buffer size specifically for small, everyday accidents.
Okay, but failsafe number 3 is my absolute favorite because it honestly sounds like science fiction.
Molecular self-destruction.
Yes.
Trypsin actually has a built-in suicide switch. There is a very specific cleavage site right on the trypsin molecule itself, located at an amino acid called arginine 122.
Arginine 122, okay.
If the concentration of active trypsin gets dangerously high, like overwhelming those SPNK1 fire extinguishers, the trypsin molecules will physically recognize that specific arginine 122 site on each other.
Then they attack each other.
They will chew each other to pieces.
Yeah.
If the environment gets too hot, the enzyme is biologically programmed to assassinate itself before it can destroy the pancreas.
Okay, let's unpack this, because this is exactly where the contradiction feels kind of glaring to me. If the pancreas has 3 incredible, highly redundant safety nets, right? Physical compartmentalization, a massive chemical fire extinguisher, and literally suicidal enzymes, how on earth does this autodigestion disaster ever actually happen?
It's the central question of the disease. And the answer is that no biological system is designed to withstand a direct, sustained override of all its safety protocols simultaneously.
Right.
Disease only occurs when one or more of these specific fail-safes are completely broken. So let's look at the triggers that cause this cellular breakdown.
Well, according to the data, the biggest culprit is gallstones.
Yes, gallstones account for anywhere from 40 to 70% of all acute pancreatitis cases. And to understand why, you kind of have to picture the anatomy.
Okay.
The duct that carries bile down from your liver and gallbladder and the duct that carries enzymes out of your pancreas, they merge together right before they empty into the intestine.
At a shared exit.
Right. This shared exit is called the ampulla of Vater. If a gallstone rolls down from the gallbladder and blocks that shared exit, you have an immediate crisis.
Yeah, I want to stop you right there, because I have always visualized this in a very specific and frankly completely incorrect way.
Oh, really?
Yeah, I always pictured a gallstone getting permanently wedged in that exit, acting like a cork in a wine bottle. And the enzymes just back up, the pressure builds, and eventually the pancreas physically bursts like a water balloon.
That makes visual sense, but
Right. But reading the sources, that is not the actual mechanism at all.
it's a very common way to visualize it, but it's fundamentally incorrect. Most of the time, the gallstone blockage is entirely transient. The stone often just passes into the gut on its own.
So it's not a permanent cork.
No. The real damage isn't a physical bursting, it's a signaling crisis. Even a temporary blockage creates a sudden, massive spike in pressure inside the pancreatic duct.
Like a shock wave.
Yes. That pressure shock wave pushes back up into the delicate acinar cells and profoundly disrupts how the cell handles calcium.
A calcium overload.
Exactly. Intracellular calcium spikes cause absolute havoc. Suddenly, those separate compartments we talked about, the lysosomes and the zymogen granules.
The first failsafe.
Right. The calcium forces them to abnormally fuse together. Cathepsin B mixes with trypsinogen right there inside the cell, activating it prematurely.
Oh, wow.
And the calcium also blocks the enzymes from being secreted out of the cell. So now you have massive premature activation happening in the locked room. It overwhelms the SPINK1 buffer in minutes.
So a gallstone creates a mechanical pressure crisis that basically overwhelms the failsafes from the outside. But what if the factory's safety equipment is just fundamentally broken from the day you were born?
Well, that brings us to hereditary pancreatitis. This was a massive medical breakthrough in 1996 by a geneticist named David Whitcomb.
Right.
He was studying families that had a bizarrely high rate of severe pancreatitis, often starting in childhood. He mapped their genetics and discovered a mutation in the PRSS1 gene.
And what exactly does that gene do?
It codes for trypsinogen. Specifically, this mutation, which is known as the R122H mutation, alters that exact amino acid we discussed earlier, arginine 122.
The suicide switch.
Yes, that genetic glitch literally erases the self-destruct switch. The trypsin functions completely normally when it comes to digesting food, but it has lost the physical mechanism to degrade itself.
So if it accidentally activates.
If a few molecules accidentally activate inside the pancreas, they cannot be turned off. The fire just burns and burns.
That is wild. The ultimate failsafe just wiped out by a single genetic typo. Which I guess brings us to the second leading cause of pancreatitis, and one that carries a lot of stigma: alcohol.
Yeah.
You might think one wild weekend causes this, or that anyone who drinks heavily is destined to destroy their pancreas.
The statistics tell a completely different and actually quite mysterious story. Only about 3 to 5% of heavy chronic drinkers ever actually develop clinical pancreatitis.
That statistic blew my mind. 3 to 5%.
It really challenges a lot of assumptions. The reality is that alcohol is a sensitizer. The toxic byproducts of breaking down ethanol alter the lipid composition of the cell membranes.
Making them weaker.
Right. It makes those zymogen granules incredibly fragile, prone to spontaneous rupture. And it also chronically messes up that intracellular calcium signaling we just talked about.
So alcohol is essentially like leaving highly flammable, oily rags scattered all over the munitions factory floor. Like, it doesn't actually start the fire itself, but it makes the entire cellular environment incredibly fragile, just waiting for a secondary spark to set the whole thing off.
I like that analogy, but I'd take it even further. It's like a factory where the sprinkler system has been turned off and the sturdy storage containers have been replaced with wet paper bags.
Wow, well.
A genetic quirk, a smoking habit, a minor transient pressure spike. Something else usually has to provide the final spark, which is why 95% of heavy drinkers never get it.
Knowing how intricately this all breaks down at a microscopic level makes the history of discovering this disease so compelling. I mean, the doctors in the 1800s, they couldn't see acinar cells.
No, not at all.
They didn't know what calcium signaling was. They were operating entirely blind, only seeing the gruesome aftermath on the autopsy table.
They were playing a very dark game of medical detective work. If we trace it back, you have the famous French physiologist Claude Bernard in 1856. He injected bile directly into the pancreatic ducts of dogs and observed this massive tissue destruction. He saw the effect, but he couldn't explain the why.
And
Then, jump to 1889, Reginald Fitz at Harvard finally categorized all these chaotic autopsy findings: the gangrenous tissue, the fat necrosis, the hemorrhaging, and he proved to the medical world that this wasn't 5 different diseases. It was one cohesive clinical syndrome.
But the real aha moment, like the actual paradigm shift, didn't happen until a few years later.
Right. In 1896, an Austrian pathologist named Hans Chiari made an incredibly bold claim. You have to remember, this was the golden age of germ theory.
Where everything was a bug.
Exactly. Every doctor assumed that severe rotting inflammation had to be caused by an outside infection, like a bacteria invading the body. But Chiari looked at the cellular destruction and made the radical claim of autodigestion.
That the body was eating itself.
He argued the organ's own machinery was turning against itself, yes.
That must have sounded insane at the time. To suggest the body is eating itself rather than fighting a bug. Why did it take so long for the medical community to fully grasp how right he was?
Well, mainly because of a very convincing competing theory by a brilliant doctor named Eugene Lindsay Opie. In 1901, at Johns Hopkins, Opie performs an autopsy on a pancreatitis patient and finds a gallstone stuck exactly at that shared anatomical junction, the ampulla of Vater.
The common channel.
Exactly. Opie proposed the common channel theory. He argued that the gallstone created a dam, forcing caustic bile from the liver to flow backward, directly up into the pancreatic duct.
And that backward flow triggered it.
Opie claimed this backward flow of bile is what triggered Chiari's autodigestion.
It is a beautiful piece of logic. I mean, you see a blockage, you see fluid backing up. It makes total mechanical sense. But today, with modern science, Opie's theory has some major holes.
Yeah, Opie was half right. He had the anatomy right, but the mechanism wrong. For 100 years, his theory completely dominated. But modern experiments showed that if you gently inject bile into a healthy pancreatic duct at normal pressure, you don't reliably trigger severe pancreatitis.
Interesting.
As we now know, the real culprit isn't the bile itself. It's the intense pressure spike from the blockage that scrambles those internal calcium signals we talked about.
So if Opie had the anatomy right, but the mechanism slightly off, how long did it take for the medical community to actually agree on what this disease is and how to properly diagnose it?
Unbelievably, it took until 2012.
2 to 12.
Yes, the revised Atlanta classification finally nailed down the universal diagnostic criteria. And the beauty of the 2012 criteria is its simplicity. To diagnose acute pancreatitis today, a patient only needs to meet 2 out of 3 criteria.
Okay, what are they?
Characteristic severe abdominal pain that radiates to the back, blood work showing elevated pancreatic enzymes, and characteristic findings on imaging like a CT scan.
I want to pause on those criteria because there are some big misconceptions here. First, you don't always need a CT scan. If someone comes into the ER with that severe radiating pain and their blood work shows enzymes are at least 3 times the normal upper limit, you have your 2 criteria. The diagnosis is made.
Right.
Sending them to the scanner is often unnecessary and can actually be misleading.
That's a crucial point. If you do a CT scan too early in the disease process, the pancreas hasn't had time to visibly swell up yet. The scan might look completely normal, and a doctor might falsely rule out pancreatitis.
And regarding that blood work, the sources are very clear that looking at an enzyme called lipase is vastly superior to looking at amylase. Why is that?
Well, amylase is an enzyme that digests carbohydrates, but it is produced all over the body. You make it in your salivary glands, your kidneys clear it. An amylase spike could mean you have a kidney issue or even just a swollen salivary gland.
But lipase is different.
Lipase, however, is an enzyme that digests fats, and it is almost exclusively manufactured by the pancreas. It is a far more specific, reliable fingerprint that the factory is leaking.
Now, the 2012 classification also makes a massive structural distinction regarding what that leak is actually doing to the tissue. It splits the disease into 2 subtypes: interstitial edematous pancreatitis versus necrotizing pancreatitis.
And this distinction is the ultimate predictor of whether a patient will survive. In interstitial edematous pancreatitis, which is the vast majority of cases, the pancreas is incredibly angry, swollen, and leaking fluid, but it retains its blood supply.
So the tissue is inflamed, but alive.
Right. But in necrotizing pancreatitis, the autodigestion has been so incredibly violent that elastase and other enzymes have melted the local blood vessels.
Oh, wow.
Entire segments of the pancreatic gland or the fat surrounding it literally die from a lack of oxygen. They become necrotic.
You have dead, rotting tissue sitting inside the abdomen. That sounds like a ticking time bomb for a massive infection.
It is exactly that. Necrotizing pancreatitis carries a profoundly higher risk of major complications and mortality. And realizing that distinction completely changed how doctors approach the disease.
Which brings us to the history of treating this. Because the pancreas is so volatile, it seems like our most logical, common-sense attempts to treat pancreatitis historically ended up being completely backward.
There are some of the most fascinating medical reversals in modern history. Let's look at feeding. For decades, the absolute ironclad rule for pancreatitis was bowel rest.
Right.
Patients were kept strictly NPO, which means nothing by mouth, for days or even weeks.
And intuitively, that logic makes total sense to me. Eating stimulates the pancreas to manufacture and release more digestive enzymes. If the organ is actively digesting itself, the very last thing you want to do is ask it to pump out more acid. You starve the patient to let the organ rest.
It is a beautifully reasoned, logical hypothesis, and it was disastrous in practice.
Because we forgot about the rest of the body.
Exactly. The problem is that starving a patient also starves the delicate cells lining their intestinal tract. The gut relies on constant food intake to maintain the tight barriers between cells. When you starve the gut, those protective barriers atrophy and break down.
Which means the bacteria living normally in your gut can escape.
Exactly. The bacteria slip through the weakened intestinal wall, migrate through the bloodstream, and find that dead, necrotic pancreatic tissue we just talked about. They colonize it, turning sterile dead tissue into a highly lethal infected abscess.
Here's where it gets really interesting. So by keeping them from eating to protect the pancreas, we were actually causing the deadly infections.
A landmark study called the Python trial finally proved this. They showed that early oral or feeding tube nutrition, started within the first 24 to 48 hours, actually nourishes the gut lining.
It maintains that barrier.
Yes, it drastically reduces infection rates, and it saves lives. We had to abandon our perfect logic because the clinical data proved it was killing people.
There was a second massive medical reversal when it came to surgery, right? Like if a patient did develop that dead, infected, necrotizing tissue, the old standard of care was aggressive open surgery.
It was called an open necrosectomy. Surgeons would slice the abdomen wide open and manually scrape and wash all the dead tissue out.
That sounds brutal.
It was a brutal, traumatizing surgery performed on patients who were already critically ill in the ICU. But then came the Panther trial in 2010. The researchers compared that aggressive surgical approach to a highly cautious step-up approach.
So what does a step-up approach actually look like?
You start with the absolute minimum intervention possible. Instead of opening the abdomen, you use radiology to guide a tiny needle through the skin and insert a small percutaneous drain directly into the infected fluid collection to siphon it off.
Just drain it.
Right. You let the body try to heal. You only escalate to minimally invasive surgery if the patient fails to improve. And the Panther trial definitively showed that this cautious, drain-first approach drastically reduced major systemic complications and death compared to open surgery.
I absolutely love that. The interventions that look the most decisive and heroic, starving the patient to rest the organ, cutting them open immediately to clear the infection, they lost out to these counterintuitive, highly cautious approaches, feeding them early and just putting in a simple little drain. It's a testament to letting the mechanism and the data dictate the treatment, not the doctor's ego.
It's a very humbling lesson for the medical field.
But surviving that acute explosion, whether you use a drain or early feeding, is really only half the battle, isn't it? Because this local gland injury doesn't just stay local. The structural damage leaves lasting legacy on the entire body.
It does. If we connect this to the bigger picture, when those activated enzymes and destroyed cellular debris spill out of the pancreas and into the general bloodstream, it triggers a massive body-wide immune panic. This is known as SIRS, Systemic Inflammatory Response Syndrome.
And that immune panic can damage organs that have nothing to do with digestion.
Exactly. In severe cases, it progresses to ARDS, Acute Respiratory Distress Syndrome. The pancreatic enzymes, particularly elastase and phospholipase, circulate in the blood and begin attacking the delicate capillary beds in the lungs.
Oh, the lungs.
Yes. The blood vessels become leaky, fluid floods into the air sacs, and the patient effectively begins drowning on dry land. A patient can be on a mechanical ventilator fighting for their life, all because of a localized cellular misfire in the abdomen.
And even if you survive the ICU, there is the chronic aftermath. The sources highlight something called the SAPE hypothesis, the sentinel acute pancreatitis event.
This is another vital concept championed by David Whitcomb. The idea is that a severe first attack, that sentinel event, acts like a biological switch. It permanently primes the immune cells inside the gland.
Okay.
If the patient has repeated attacks, say from continued alcohol use or a genetic susceptibility, the pancreas loses the ability to heal properly. Instead of regenerating healthy acinar cells, it lays down rigid, non-functional scar tissue.
Which leads to chronic pancreatitis, meaning the factory is effectively shut down. You develop exocrine pancreatic insufficiency, where you literally cannot absorb the nutrients in the food you eat, no matter how much you consume.
And you eventually lose the specialized islet cells that manufacture insulin, leading to an incredibly brittle form of diabetes known as type 3C. It's a complex, incredibly painful, chronic condition that completely reshapes a patient's life.
And we have to mention the most sobering reality of all here. This chronic inflammation, this constant cycle of scarring and rapid cell turnover, is a major identifiable pathway to pancreatic cancer.
It is. The ongoing autodigestion creates a highly chaotic cellular environment. The constant damage and repair significantly increase the risk of the genetic mutations that lead to one of oncology's deadliest diagnoses.
Okay, let's take a breath and pull all of this together. Pancreatitis isn't just a generic infection. It's not a simple plumbing blockage where a gallstone acts like a cork. It is a profound mechanical failure where the body's own elaborate fail-safes, from compartment barriers to suicidal enzymes, are completely overridden, turning the entire digestive process inward.
From transient pressure spikes, scrambling calcium signals, to genetic mutations erasing the self-destruct switch, to alcohol acting as a cellular sensitizer, it really is a disease of pure autodigestion.
So what does this all mean for you? It means understanding that the fundamental mechanism of a disease dictates exactly how we treat it. Realizing that pancreatitis is a disease of premature enzyme activation rather than a bacterial infection is what eventually guided us to the right diagnostic criteria.
Right.
Understanding how the gut barrier functions is what finally stopped us from starving patients. And respecting the chaotic inflammation is what stopped us from rushing them into dangerous open surgeries. The how entirely dictates the what to do.
That is exactly right.
I want to leave you with a final thought to mull over today. We spend so much time marveling at how modern medicine treats complex diseases. We marvel at how radiologists can thread tiny drains into infected tissue, or how geneticists can map specific mutations like PRSS1. But perhaps the real miracle isn't the medicine at all.
No.
Perhaps the real miracle is the healthy human body. Every single day, your pancreas manufactures, stores, and transports a chemical payload powerful enough to literally melt a steak. And it manages to do so day in and day out for a lifetime, usually without a single misfire. The true wonder isn't just surviving the explosion. The true wonder is the quiet, everyday perfection of the containment.
That is the perfect way to look at it.
Thanks for diving deep with us today.